and we're honored to have him here today. With that, I'll turn it over to Srini.
Thanks a lot, Abhi. I'm honored to present to you guys and kind of show you some basics. I mean, this is kind of, you know, there's many, as we all know it as interventional radiologists, there's many ways to do all these things. And this is kind of the way I think about it and the way that I kind of show our fellows. We have 8 interventional radiology fellows. And so it's always interesting to hear all their perspectives. But again, this is kind of the way I look at things and the way I see things. And I try to post a lot of this stuff on YouTube, just like you guys do on my vascular channel. And so I'm going to be having a lot of talks on stroke and venous disease and PE and stuff in the next several months. So today we're going to talk about infrapopliteal and inframalleolar artery interventions. These are my disclosures. Obviously, when you guys are treating or getting into CLI, you're going to see patients like this. These are a lot of the types of patients you'll see, you know, commonly when you're treating CLI patients. And everybody wants to have reconstructions like this where they have a nice 3-vessel tibial runoff and so forth. But to do that, you really have to understand anatomy. You want to understand not only just the basics, which we all do, but you want to understand things like, well, we know that the perineal artery is a much more important vessel than I think most people would think, mainly because I like to think of it as like the profunda of the vasculature below the knee. You know, it gives you really big, robust collaterals with an anterior and posterior communicating branch, as you can see in that far right there with the arrows, to really help you in cases where the anterior tibial and posterior tibial arteries are occluded, right? It gives you a lot of collateral flow. So I actually think it's a much more important vessel than we give it credit for. Obviously, normal anatomy is good, but you have to understand some of the common tibial artery variants. And then really 2 of the most common is the perineal artery, which is continuous into a dorsalis pedis artery. The tip off here is that typically you have a diffusely enlarged perineal artery, and oftentimes you'll have a small or congenitally absent anterior tibial artery. And as you can see here on the far right, that perineal really continues in the expected course of the dorsalis pedis as it crosses the ankle. And here's another common tibial artery variant, which is the perineal artery continuous into a posterior tibial artery. And then obviously supplying the pedal plantar loop, which we'll talk about in a few minutes. When we talk about below ankle anatomy, things change again. I think this is one place where people don't spend a lot of time, you know, really trying to become experts at, and I think it's very important. When you think of the below ankle anatomy, I think 2 important things. The first one is the arcuate artery. And if you look at this diagram, you can see really the arcuate artery is really one of the first branches, one of the main branches of the dorsalis pedis artery. Really crosses horizontally across the metatarsal bones in the middle foot, and then anastomoses with the lateral tarsal arteries to come back to the DP or the AT. And so it is a main, but the one that most commonly people talk about is this pedal plantar loop. And what that means is that's basically, if you look at the web space between the first and second metatarsals at their bases, the dorsalis pedis artery will give off what's called either a communicating artery, a perforating artery of the pedal plantar loop, and then that is continuous with the lateral plantar artery and then coming back to the posterior tibial artery. And I'm going to show you what that looks like. So these are 2 important loops or anastomoses within the foot, but remember that the first one related to the arcuate artery is only present in about 17% of patients. So here's what we're talking about. So here's your very common pedal plantar loop. Obviously, everybody knows the anterior tibial artery continues. Once it gets to the ankle joint, it becomes the dorsalis pedis artery. Then at the base of the first and second metatarsal, you can see that red arrow there. You can see that it really gives you that deep perforating artery or communicating artery, which is then continuous with the lateral plantar artery and then the posterior tibial artery. So there's your classic pedal plantar loop that we're talking about. Here is your classic arcuate artery loop. It's basically the DP giving off the arcuate artery at the bases of the metatarsals. It crosses horizontally and then joins by the lateral tarsal arteries back to the anterior tibial artery. So it's another common loop, but again, only present 17% of the time. So when most people are saying pedal loop anatomy, pedal loop interventions, below ankle interventions, they're really most commonly talking about the first one that I talked about, which is the pedal plantar loop in red. Remember though, even though that's normal anatomy, there are a lot of pedal loop variations. And so this is what makes below ankle interventions very difficult, because a lot of times you're not dealing with normal open vessels. You're dealing basically with vessels that are occluded, that are highly stenotic or diseased. And a lot of times you won't know if you're in the right place or not. So it's not, every case when they're showing, stuff on Twitter or social media and so forth, and they're like, look at this pedal plantar loop reconstruction. Most of the time that's normal kind of anatomy where, we were luckily to be successful. Obviously, pedal loop and below ankle interventions, you really want to undertake those only in the setting of true limb salvage where there's really no other options, because there are risks in terms of, there's a high complication. I'm sorry, the complications can be disastrous, right? So you obviously want to undertake this only in the most severe cases. So let's talk about angiography. So how do I do below knee and below ankle angiography? So I think if you're going to be fixing things below the knee and below the ankle, it really helps to go antegrade if you can. So antegrade CFA or even proximal SFA access, typically with a 6 French sheath, with the tip really as distal as possible, ideally in the P2 or P3 segment, so the mid or distal segment of the popliteal artery. And then that gives you really high quality angiograms, and you always want to include AP and lateral views. Remember, we're not talking about in the days when I was a fellow at Miami Vascular, where we were doing basically vessels which were diseased but open for the most part, or short segment occlusions. We are talking about true CLI now with long segment CTOs, heavily calcified, disease from groin to toe and foot. And so you really need to understand what the outflow is, just like the inflow. So AP views are very important, and good angiography allows for really optimal assessment of really the caps in terms of proximal and distal caps of chronic total occlusions, collaterals, distal targets, and obviously helps you determine what your access sites and treatment will be. And I'm going to show you some examples of this so it at least makes more sense. So here's an example of why putting your sheath as distal as possible makes a difference when you're dealing specifically with below knee and definitely below ankle interventions. Here's an angiogram. I have antegrade access, I have a common femoral artery sheath, and I'm doing an injection. And I did the same injection in 2 different locations. So here's the first one. And I think everybody will say, well, at the knee joint, the P2 segment of the popliteal artery is occluded. There's some collaterals, and I'm not really sure what's reconstituting below that. Look at the difference when your sheath is in the distal popliteal artery. Same injection, same contrast, same volume. You can see now you've got really robust filling of these large collaterals. And now it looks like from that P2 occlusion, I've got huge collaterals coming off. It's a very complex cap. Trying to recanalize this, I'm going to get caught in those branches. I'm probably not going to have a good initial recanalization. But now I see that there's a little course right there. And so I punctured the anterior tibial, and now you can see that recanalization all of a sudden became a very quick one in really less than 5-10 seconds. So it shows you the difference in angiography and what you see depending on where your sheath is. In terms of how you position the knee, the classic thinking is let's do a nice AP knee X-ray, and that'll show us all the tibial vessels, and that is a good way to do it. But I will tell you, in doing hundreds and hundreds of these cases over the years, is that you can see that if you do a little bit of an oblique where the fibula and tibia overlap, like in that middle image, now all of a sudden all the branches of the tibial vessels are splayed out, they're separated, and it's a good working angle to try to do your interventions. What about below ankle interventions? Now I need to get a good AP angiogram of the foot, a good lateral view of the foot. What is the best technique? How should we do it? Well, it's just like what you would expect. You want a good AP foot X-ray. For those of us that are all IRs and radiologists, in our training, we understand what a good AP foot X-ray looks like. And that's really, and if you look at that top image, this is from Marco Manzi's article in, I think it was Radiographics in 2011. This is a really excellent article if you want to understand how to image and understand vascular anatomy in terms of pedal plantar loop. And you can see the II is basically horizontal to the foot. I have a nice AP X-ray of the foot. And the reason that's important is if you look at that lower left image, is that the arrow of that box is that shows you where that deep perforating artery of the pedal plantar loop is hopefully going to start taking its turn. And I'm going to show you examples of that to really drive this point home. And if you look at the image to the right, the angiogram, again, there's that first and second metatarsal base right in between them. There's your communicating or perforating artery coming around, and you can follow it, joining the lateral plantar and back to the posterior tibial artery. So you can see this gives you a really good idea of what the anatomy should look like. So now what about the lateral foot? What's important on the lateral foot? So again, we want a lateral foot x-ray. If you look, the II is parallel to the foot. If you look at that x-ray far left, or that fluoroscopic image, you can see, what am I looking for? I'm looking for the fibula and the tibia being overlapped. I'm looking at the base of the fifth metatarsal is separated from the rest of the bones in the foot. And the reason for that is because then when you look at that far right image or the angiogram, it basically gives you a nice clear view of the common plantar artery and its two main branches, the medial plantar artery and the lateral plantar artery, which then joins the deep perforating artery and then comes back to the dorsalis pedis artery and the AT to give you your pedoplantar loop. So that's what you're looking for. I think this is a good way to look at things. And there's the base of the fifth, and there's your pedoplantar loop coming from the antegrade direction on the anterior circulation. So again, to drive this point home, let's look at it, because repetition really helps in these cases. That if you look on the left, there's a normal angiogram of the pedoplantar loop. So if you look at that black arrow to the farthest to the left, you can see at the base of the first and second metatarsal, again, we've got the deep perforating artery, or the communicating branch from the dorsalis pedis. That's where it makes its first turn. It comes to around the base of the third, maybe the base of the fourth, depending on the obliquity you have in your imaging, to then join the lateral plantar artery and then back to the posterior tibial artery. Remember that there are classification systems for the pedal arch, and it's not that everybody uses this classification system, but I think it's important to understand it and know that one exists. I actually think this is a good paper by Kawarda, and really in this paper they're talking more about wound healing and the status of the pedal loop in terms of what makes a difference for healing in terms of rate and speed and so forth. And so it's not a bad article to just understand. Again, some people will describe, pedal arches by these types, 1, 2A, 2B, 3, mainly because it makes it more descriptive, and they'll say it's a Kawarda type 2B or something, and that's really helpful in some cases. So let me show you now, for those of you who have never seen what navigating the pedoplantar loop looks like, is again, I'm showing you that angiogram, which is normal on the far left, and then now I want you to watch the angiogram to the right. There's our pedoplantar loop, excuse me. And I want you to notice I have a CTO catheter, and notice that bending at the red arrow, that prolapse that's occurring. That prolapse is the clue of where that first bend is. And so then you can take your guide wire. I'm using a CTO catheter, a CXI in this case, and a Command 14. You can use a Command 18, a Fielder, or Regalia. There's a whole bunch of different types you can use. And basically that's where your first branch is. Now at the base of the third is your second branch. And so in this case, this patient had classic anatomy and everything kind of fit, and then you can see your wire go. So there's your pedoplantar loop. So when you look at the pedal loop on the lateral view, it looks like it's so wide, but if you notice, it's actually pretty narrow in the AP view. And then obviously once you've done your recanalization, or you've traversed this loop, you obviously want to inject contrast and always show that, are you true lumen, are you intraluminal, and are you actually in a vessel that you think you're in? So what are some common features of below knee disease? Well, you're obviously dealing with CTOs, typically long diffuse chronic total occlusions. They're heavily calcified 75% of the time compared to above knee disease, especially in diabetics and patients with CKD. And there's some early histologic work that's shown that there's cells of cartilage and bone in these occlusions. And so you can imagine trying to recanalize these sometimes can be very difficult, or sometimes not even possible. And the other thing that makes them challenging is that you don't have a lot of bailout options when you're dealing with below knee and below ankle disease in terms of dealing with dissections and perforations like you do, say, in an iliac artery or an SFA or even a popliteal artery. If you've never seen what a CTO looks like, this is what it looks like in cross-section under a microscope. So all the little black arrows on each picture there are showing you microchannels. And so this is why people talk about guide wire escalation. I'm going to start with 014, and then I'm going to try 018 and then 035, because you're trying to get your guide wire to basically get into one of these small microchannels to start your recanalization. And again, depending on who you talk, if you talk to cardiologists, a lot of them will talk about guidewire escalation. I like to start small, 014, then go to 018, etc. If you talk to IRs, a lot of them you'll get a little bit of a third here, a third there, and a third there. It just depends. When you talk to vascular surgeons, then a lot of them tend to be more into 035 systems, and that just depends on training and so forth. Obviously, I'm generalizing, but overall, people that become experts in this stuff will understand all the different guide wire diameters and systems that can be used. I think another important point when you're dealing with below knee and below ankle disease are CTO cap types. Obviously, when you have a chronic total occlusion, you've got a proximal and distal caps. You may have different caps along the length of the occlusion. And this is from a paper written by Mustafa et al. On CTOP classification. Even if you don't understand type 1, 2, 3, and 4, and you don't have them memorized, that's not the important part. The important part, in my opinion, is just looking at the proximal and distal caps and understanding, should I start antegrade, should I start retrograde, etc., and so forth. So for instance, if you look at type 1, because of that shape of that proximal cap, I'm most likely going to start intraluminal when I do my recanalization. Where I end up obviously depends on how my recanalization goes. But when you look at types 3 and 4, my guide wire and catheter most likely are going to hit that cap, slide off to the side, and now I've initiated a subintimal recanalization. And so I have to then start thinking about how am I going to re-enter or come back to the true lumen. So just keep an eye on it. Another important concept is what's called hibernating and non-hibernating lumens. Remember, when you have CTOs, I think we classically would always think of them as, well, it's occluded from start to finish. But remember that in a hibernating lumen, you have a proximal cap, a distal cap, and in between is open. And that is hibernating because it's angiographically occult. You don't know that until you start your recanalization. Sometimes you can look with ultrasound, that may give you a clue. When you have a non-hibernating lumen, it basically means that you're basically occluded from the proximal to distal cap, and you have to fight your way through that entire recanalization. And so let's look at what that means. So here's an example of hibernating vessels. So what does that mean? That means that in this case, I didn't know this at the time, but I knew now that there's an open blood vessel down there. It's just that it's angiographically occult. I'm not seeing it. And so you can see there's a CLI patient with a distal posterior tibial artery occlusion. And once I did my recanalization, I had good blood return, did a good injection, and we have a nice hibernating lateral plantar artery with an angiographic wound blush. So this is a good example of a hibernating vessel. In this case, it's another example, which again, you're not going to know until you start your recanalization. You know, I have another CLI patient who's really got a robust perineal artery with anterior and posterior communicating arteries. The red arrow is really showing you the DP stump, or the dorsalis pedis artery stump. And so once we do our recanalization, I get my catheter to the red arrow. I have blood return. I do a good injection, and look at how many blood vessels are filling in this foot. So there's a lot more there than meets the eye. So again, these are hibernating vessels. In some cases, you do your recanalization, and then you're just fighting your way every step of the way. So here's an example of where there was no hibernating vessels. It was basically occluded from top to bottom. And even once I got down here, I'm still fighting my way. And I think you can see there's some kind of tram tracking of calcification of these of the medial and lateral plantar artery, which are pretty heavily calcified in this diabetic CKD patient. And so in this case, I wasn't successful, and there's nothing I could do about it. What about direct and indirect revascularization? You know, everybody's talking about angiosomes, and for those of you that are starting out, you know, you need to understand the concept. So direct revascularization, and I'm going to show you an example of that. Maybe I'll come back to this paper. So when you think of direct revascularization, you are basically opening up a blood vessel that directly supplies the abnormality in the leg or the foot. So maybe it's an anterior tibial artery that supplies a wound at the top of the foot. You're opening that up. And when you're talking about indirect revascularization, we're basically talking about you can't open up the blood vessels that directly supply the abnormality, so you open up a different blood vessel, and then collateral vessels fill and then perfuse the area, the abnormal area. So that's an indirect revascularization. And so what I'm going to show you with the first case is this is an example of a direct revascularization. Obviously, you've got a CLI patient who's clearly got ischemic changes and got areas of gangrene and small ulceration, has dependent rubor, etc., has a dorsalis pedis artery that's completely out, And so in this case, I was able to do a direct revascularization because I recanalized and opened up the anterior tibial artery. We had a lot of hibernating vessels in the pedal plantar loop, so we were able to be successful with a good vessel prep and angioplasty. And you can see on the far bottom right that that was the end result, 2 weeks after we had fixed him. So that's an example of direct revascularization because I opened up the blood vessel that was supplying the abnormality of interest directly. Now here's an example of an indirect revascularization. So in this case, we've got another CLI patient who underwent a TMA. Unfortunately, she had wound dehiscence and was not healing, and now she's at risk for really an AKA in this case. And so if you look at the far left on the top there, there's my angiogram. I've got antegrade access. I have a sheath in the distal popliteal artery, and at the knee joint, it's occluded. There's really no named vessels below that. And so I was unable to recanalize the anterior tibial artery and the posterior tibial artery, which would have been ideal in this case to have a nice pedal loop to heal this wound due to the patient had really diabetes and CKD, and I could just not get through these the entire things were occluded. I couldn't get through, but I was able to recanalize the perineal artery, and in this case, it's pretty robust. And if you look at that image there now, next to the color image, you basically have a nice lateral foot angiogram, which is showing you the importance of this perineal artery, giving huge anterior and posterior communicating branches and filling all these robust hibernating vessels in the foot, and luckily she ultimately went on to heal. And so that's an example of indirect revascularization. So now let's talk about some CTO crossing techniques. Everybody talks about you got to cross that CTO, but what I realized when I was learning decades ago, which is really telling you how old I am, is that nobody really would tell you how they did the recanalization. It was kind of learned by watching. But now there's so much stuff on the internet, there's so many publications on this, and a lot of them have names, and so it's easy to kind of learn this stuff now, reading courses, conferences, talking to people that do this stuff on a daily basis and so forth. So let's go over some of these CTO crossing techniques. So the first one is the penetration and drilling technique. These are two techniques. The penetration technique is where you have a CTO wire, and you're basically turning it back and forth with a little bit of forward pressure, trying to puncture that proximal cap so you can do your recanalization. The drilling technique, on the other hand, is you're basically rotating the wire 360 degrees. You're basically rotating it like a drill, either clockwise or counterclockwise, take your pick. And then you're doing that to initially break through the cap and then obviously do your recanalization. So let's look at an example of that. And well, I guess before I show you that, let me tell you about Guidewire Tip Load. So when you're dealing with penetration and drilling techniques, the Guidewire Tip Load is very important. And the reason for that is because you need a Guidewire tip that doesn't prolapse or bend easily. So what does that mean? So Guidewire Tip Load is basically the minimum grams of pressure needed to deflect or buckle the distal 1 centimeter of a guide wire 2 millimeters. That's how they define Guidewire Tip Load. And so people will say, I used a 4-gram tip, I used a 30-gram tip. So if you think of a V14, V18 guide wires, around a 4-gram tip wire. If you think of like a Abbott 250T, that's a 30-gram tip wire. So you can see that there's a huge range, and understanding this will really help you in this case because you want a high tip load guide wire. And here's an example of what tip load looks like. So on the left, I've got an image of a low tip load guide wire, 2 to 4 grams. In the middle, I've got maybe 10, 12 grams. On the far right is a 30-gram tip load. And I want you to look at how much bending or prolapse of the distal tip you get when you have a low tip load guide wire trying to do a recanalization. Look at that, the amount of prolapse you get. The middle you have less, and on the far right, it almost doesn't bend at all. But then the problem is that it's more likely to dissect and perforate and do things like that. So you have to just be careful with higher tip load guide wires. So in this case, I have a CLI patient who's got basically no AT, no PT, has a diseased perineum with a short CTO in the TP trunk. So I have my CTO catheter because I want to do this recanalization. I'm antegrade, and I'm using a high tip load guide wire with penetration technique. So I'm rotating back and forth to kind of break that cap. Once I break that cap, then I decided to convert over to a drilling technique where I'm rotating the wire 360 degrees, whichever direction is comfortable to you, to ultimately do that recanalization. So there's a good example of a high tip load guide wire using penetration and drilling technique. Let's look at this case example. So here's a CLI patient who has an abnormality or a wound in the distribution of the anterior tibial artery. So I'm thinking direct revascularization. And basically my path is I want to recanalize the AT and then eventually get to the pedal loop, assuming that it's not hibernating, and I have a shot at doing a successful recanalization. So if you look at this guide wire now, again, I have a guide wire with a relatively high tip load, and I'm using a penetration technique because I'm rotating it back and forth. And I get through the CTO, and then you can see the rest of it distally is basically hibernating, because look at how quickly that guide wire got through once I got to really that distal anterior tibial artery. Look at that. That's basically, and the reason is because it's an open channel, so things just go very quickly through there, right? And then obviously I check to make sure. I do my injection through a catheter, and I basically prove that there are a lot more hibernating vessels in the foot than we thought. Ultimately, I do good vessel prep. You can do either angioplasty with scoring balloons, vessel prep with atherectomy, and then once you do that, you do a nice slow, long, low pressure inflation of a balloon to ultimately achieve, a nice angiographic result and then hopefully healing. So let's talk about the knuckle wire technique. With the knuckle wire technique, in this case, you're basically taking a low profile guide wire and you're making a small loop. So you want it to form that loop, and then you're using that to do your recanalization. If you're intraluminal, then you'll be in the middle of the vessel and you'll be able to do your recan that way. If your recanalization, hits a cap that's unfavorable and you end up becoming subintimal, then you'll be in that subintimal plane, which is that middle image. And then you're going to need either a catheter and maybe heavier tip load guide wires, or even a reentry device to help you get back into the true lumen to finish your recanalization. And the graphic on the right is to show you when you have dual access, the same thing applies. I have a guide wire from above, which is stuck in the proximal CTO cap. I have a guide wire from below, which became subintimal, and I'm going to use a knuckle wire technique to kind of rotate and create a channel and then get through and through access. And so let me show you an example of what that looks like in real time, because I think that really drives the point home. So again, here's that patient we saw. Here's this anterior tibial artery, and you can see that after looking at this, I decided that, my best chance is let's go after this anterior tibial, because it looks like there's some CTOs, there's some high-grade narrowings, and maybe we got some hibernating vessels in the foot, which we know. So you can see on that middle image, I have a low tip load guide wire, and I'm basically forcing it to form a loop, as you saw, and then I'm basically pushing the guide wire. That's a nice knuckle wire technique, so I'm doing my recanalization that way. On the far right, we're using basically a catheter and a penetrating technique to break or get through that proximal cap. And then I did an old technique, which is you just push the entire system through that CTO, and and that's a feel thing. You're feeling that you're still in the vessel and following the course. So those are kind of showing a bunch of the techniques we've already talked about, but the key is the knuckle wire technique in the middle. And then obviously, I did good vessel prep, did atherectomy, in this case orbital atherectomy, did a good prolonged angioplasty, low pressure, and then we had a nice angiographic result. And then this is what I showed you with that direct revascularization. So here's another case which shows two strategies to the same problem. So now we have a CLI patient who you can tell has really chronic ischemic changes. They've got shiny hairless skin, they've got thickened nails, they've got this huge wound which is down to the tendons. This patient really is at risk for a major amputation, and so we have to really figure out what we can do. Here's what the initial angiogram looked like. So if you look at this angiogram, you can see there's basically major long segment occlusions of the anterior tibial artery, the TP trunk, the perineal, and the posterior tibial. There may be reconstitution of the distal posterior tibial artery on the far right, just above the ankle joint on that last image. But overall, we're in dire straits. This is a major revascularization, in terms of percutaneous options. And there's really no good surgical options here. This patient had a lot of comorbidities. They didn't have a good vein. Nobody wants us to use PTFE in this case. And so this is a patient that really cannot undergo a major surgery anyway. And so you really need to do something percutaneously. And so I knew looking at this case that I would need access from above as well as access from below. So in this case, I used ultrasound. I saw a little bit of a pulsating dorsalis pedis artery in the foot. So I thought to myself, this might be hibernating. So I accessed it. I have a CTO catheter from below. I've got a low tip load guide wire, and you can see I'm using a knuckle wire technique on that far left to do my initial recanalization of the anterior tibial artery. And then on the middle image, I got to that point and I thought, oh, this is great, I'm done. I'm like so good at this. And then I realized I'm in a completely subintimal plane. And so you can see how a lot of times these recanalizations, they kind of fool you. You think you're, oh, this is great, I'm in a great spot, and then you end up someplace where you really don't want to be. And so at that point, what I did was I pulled the whole catheter and guide wire system from below down, and then I attempted the recanalization antegrade from above because I knew I could be intraluminal for that first few centimeters. And now I'm stuck in two different subintimal planes. So I think this is a good example of showing you what a lot of people talk about, right? I have a catheter and guide wire from above. I have a catheter and guide wire from below in that far right image. And I'm in two separate subintimal planes within the same anterior tibial artery. So there are two strategies to deal with this. Here's the first few you can use. You can do these, what they call cart, reverse cart, and the double balloon or safari technique. So what is cart? Cart just means I'm putting a balloon from below. Typically in below knee disease, you want to use a 2.5 to 3 millimeter balloon so that you can create a nice big channel from below, and then you use your guide wire from above, you know, a heavy tip load guide wire to basically regain access into that channel and have through and through access. Reverse cart just means you're putting your balloon from above and doing the same thing and gaining access from below to get through and through access. And then the double balloon or safari obviously means you're using two balloons, one from above, one from below, creating a big cavity or channel there, and then you're getting access. You're basically trying to disrupt the tissue between these two different subintimal planes. So here's an example, and what I did in this case is I did a reverse cart. I put a balloon from above, created my channel, then I was able to use my guide wire and catheter system from below and ultimately recanalize to get through and through access. And on the far right, I'm externalizing the wire. So when people say I externalize the wire, they basically are just saying they advance that wire from below through a catheter and ultimately the sheath to basically get a floss, right? They've got guide wire sticking out the groin, guide wire sticking out the foot, and now I've got through and through access. And then at that point, you can basically remove your catheters and put a catheter from the groin, put it all the way down to as far as it will go. I did an injection. You can see there's extravasation at the pedal access site, which is really expected, right? You've got a hole there. That's nothing to be surprised about. But once you finish your recanalization, you're going to do a prolonged balloon inflation there because it is a diseased artery. It's not a normal, healthy artery anyway. And then you can see that once I had my balloon inflated in the distal tibial artery, I used another guide wire to make sure I got into the pedal loop and then was able to deliver therapy. The other strategy you can use when you're in the same situation is what's called Navi bossing. So Navi bossing just means that I have a 4 French Terumo Navi cross catheter from above. It's an 035 lumen. I have in this case, a CXI 018 catheter with a guide wire from below. And then if you look at that middle, if you look at that far left, you can see I'm in two different subintimal planes. If you look at the catheters and the guide wires, I'm clearly not in the same tissue plane, right? In the middle now, I'm using that Navi cross catheter to basically disrupt the tissue between the two separate channels. And that's why I'm rotating it, I'm pushing it, I'm pulling it back. I'm basically trying to, in a way, it's almost like a daughter technique. I'm creating this channel that's there. And so then once I did that, I was ultimately able to get my catheter and guide wire into that catheter, pull it through the groin, and now I can reverse my access or whatever I need to do to deliver therapy. In this case, I had a 6 French sheath in the dorsalis and the distal ATA. And what I did was I opened the side port so that when I did orbital atherectomy, I could let a lot of the debris drain out. And that's what it looks like. And you can see I'm letting the debris, and as the channel opens up, you can see how it starts dripping at the sheath. Then I did a nice, slow, low pressure inflation, 2 to 3 minutes angioplasty through the entire course of the AT and DP. And ultimately I was able, and then obviously fixed some of the other tibials as well. And then I was ultimately able to achieve a nice 2-vessel continuous runoff to the foot with a lot of good hibernating vessels below the ankle, which is what helped us out tremendously. And you can see on this final angiographic lateral foot, that's the pre and the post, we have a nice angiographic wound blush. And so that gives us, you know, some confidence that we're going to at least promote healing. And then this is the amount of healing we got over the course of 8 months. So you can see that in this case, we were lucky and able to do a good job in this case. Obviously, we've talked about CART as a slide lent to me by Kumar Madasari. This is an example of CART variation. And what it is that, you know, you've got the balloon from below, but instead of using just a guide wire from above in the CTO, I have a reentry device. You puncture the balloon. You then basically advance your guide wire, use a micro snare from below. There it is right there, 4mm snare, pedal access, and then you pull the wire out the pedal access site. So now you've got your through and through access, and you can deliver your therapy. Another common thing that, you know, is really, a lot of this has been written about by Dr. Vandenberg in Switzerland, who shows amazing examples of transcollateral recanalizations, is that, you know, you're unable to open up the direct vessel to an area, but there's some large collaterals. And in this case, you can see this catheter is down the perineal artery. It's going out its anterior communicating branch and the collateral, and ultimately they're able to get their wire and balloon into the anterior tibial artery and dorsalis, well, really into the anterior tibial artery because they didn't cross the ankle joint, and then do a good angioplasty and show you a good example of a transcollateral indirect revascularization. So let's look at a CLI case, another one to kind of drive home some of these points. So here's a patient with CLI in the distribution and a large wound in the distribution of the anterior tibial artery. You can see the AT is occluded, and it's a complex proximal cap, right? It's got multiple branches coming off of it. So we don't really know where that cap is. Like, is our wire, most likely your wire is going to go into those branches, or it's going to go into a subintimal space right away. And so when I was looking at this, I thought to myself, let me puncture the foot. That's my best chance. I'm going to need dual access again. We don't have much in the foot angiographically, so hopefully we've got a lot of hibernating vessels, which you can look with ultrasound, and you may see a kind of a low pressure pulsating dorsalis pedis or AT, then you know it's hibernating for sure. And so same thing, I punctured from below. I have a catheter and a low tip load guide wire, and you can see I'm using a knuckle wire technique where I'm pushing and rotating and twisting and doing my recanalization. But you can see on the middle image that once again, I recanned up, but now I'm nowhere near where that proximal cap is. I'm clearly in a different subintimal plane. And so what did I do? I pulled the system back, and then I decide, let me try from above, because I have to meet somewhere in the middle, right? So you can see now I've got a catheter. I've got again an 018 guide wire in this case that I'm using to basically get into that proximal cap. And then you can see that I'm trying to get my catheter and guide wire near that other one, and clearly I'm in two different subintimal planes. And the way you can see that is you can see it on the far right, where I'm using, again, now it's a 4 French Navy cross catheter. I advance it. The wires are crossing each other in different obliquities. If you notice that, see how that's crossing there? So when I did different obliques, they were basically touching. So I knew that there's some level of communication in that area, but I couldn't get the guide wire through even there. So I did some, what we went over, did Navi bossing. Ultimately, I was able to get my catheter and guide wire into that 4 French Navy cross and externalize it. And then I was able to reverse my access. You can see our tech is putting his hand on the puncture site, which I don't recommend because it was oozing or bleeding. And we got through, and then we ultimately did long, prolonged angioplasty after good vessel prep, and then we were able to achieve a nice, 3-vessel recanalization and ultimate healing of this patient's wound. And this is what it looks like real time. So here's the angiogram post-intervention. You can see there's nice filling of the pedal plantar loop. Remember, AT to DP to deep perforating artery at the base of the first, second metatarsal, coming around, joining the lateral plantar artery, and then back to the common plantar and posterior tibial, your classic pedal plantar loop. But one thing I want you to notice is this is where the AP and lateral views help you. If you look at the red arrows, I am showing a nice CLI endpoint. People always talk about CLI endpoints. Well, what is a CLI endpoint? A CLI endpoint basically means that you've got more vessels open than when you started, you've got continuous inline flow, you've got perhaps faster flow, and you've got an angiographic wound blush, which is what the red arrow is showing on the AP and lateral view. And this patient ultimately went on to heal that huge wound on their great toe without an amputation. But what about bad outflow? We've been talking a lot about tibial disease, and people talk a lot about this, but what about when you have cases like this with bad outflow? What do you got to do? Well, there's some basic concepts. One is access. So obviously you can do an antegrade recanalization of the pedal plantar loop from the anterior tibial artery. So you can go after it like this. You can do it the other way, where you go posteriorly like this, That's another option. But you also have to understand pedal access, because there's different ways to access these vessels. Obviously, many of us are familiar with ultrasound, and if you look at the top there under ultrasound posterior tibial artery, that's a normal posterior tibial artery with its paired veins in the foot. That's not what it looks like the most of the time when you're dealing with CLI patients. It looks more like the one in the bottom or worse, where it's heavily calcified or you can't find it or you can't see it. And there's obviously different ways to access these vessels. There's ultrasound, there's fluoro guided. You know, you have a heavily calcified AT and DP, as in this case. It's pretty easy to see it and puncture it under fluoro like one of our fellows did and basically put a guide wire in. Or finally, like the way we used to do PICCs in the old days, is we would do a venogram, and then you would stick the vein with using Seldinger technique, puncture through and through, pull back, you see extravasation of contrast, you know you're now true lumen, and you advance your wire. That's another contrast approach to pedal access. But remember, we always talk about retrograde access. Everything's retrograde, retrograde. You can also do antegrade, especially in extreme CLI cases where it's extreme limb salvage and you have really no other options. This is a patient that has CLI. They're ready. At this point, they're getting an amputation. So you're basically pulling out all the stops. You puncture the DP, you go antegrade, you recanalize the pedal-plantar loop in an antegrade fashion. You can obviously do retrograde in the foot as well. You can puncture, again, if you look here, they're puncturing really distal in the foot and doing a retrograde recanalization of the pedal-plantar loop. Or maybe you need multiple access sites, as in this case. A good friend of mine, Art Lee, is an interventional cardiologist, did this case. And you can see he has multiple, he punctured really the lateral plantar artery, and he punctured probably a digital or a DP or something. He's got multiple access sites to achieve success in this case. Finally, there's digital access. So digital access just means you've got, basically, you're going after occluded or open arteries in the toes. So you've gone really now to the next level of access. So here's a classic CLI patient, great toe ulcer, 4th and 5th toe amputations. We punctured he's really got nothing below the knee joint, no named vessels, and nothing really below the ankle. So at this point, this is a AKA or BKA until proven otherwise, right? There's really no other options here. And so we went ahead and got 2 different accesses. We got digital artery access. I got access into a pedal vessel. Ultimately, I was able to get, if you look at this video save here, I was basically able to get access from above and below, and I'm doing a reverse cart plus a knuckle. It's kind of like a combo, right? My wire is a knuckle, I have a balloon there, and trying to get through. I ultimately was able to get through and do nice vessel prep and angioplasty. And then I was able to get inline flow into one vessel, the anterior tibial vessel. And, you know, people looking at this might say, oh, come on, that's not going to heal everything this guy has. Well, of course not. But remember, I started from nothing, and now we have one vessel. And so now we can send the patient home, bring them back in a week or 2 weeks, and really go after the posterior tibial artery and maybe the pedal-plantar loop at that point. So this allows you to bring the patient back to fight another day, so that you don't have to fix everything all at once. You know, if you can, I think staging procedures is one of the most important things in CLI. Fix part of it, and then fix the second part of it or the third part of it. You don't have to do everything at one sitting, because these procedures can be long and you'll get tired. So what about below ankle crossing? Well, when you're crossing, you know, disease below the ankle, it really includes a combination of multiple techniques in terms of microchannel navigation. You can try to do it subintimal, but ideally you want to try to be as intraluminal as possible. These are small vessels, they're fragile, you don't have a lot of bailout options. And you'll use really a combination of all the crossing techniques that we talked about. And a lot of times you're using softer wires, you know, because they are fragile vessels, I'm sorry. You know, these are some of the common catheter systems that I've used or people have used over the years. One is using an 014 or 018 CTO catheter. Take your pick, every company makes them. You can use CXI, you can use Corsair, Fine Cross, etc. Some people use a dual catheter system where they basically take a 4 French Navi cross as low as possible, and then they put in 018, Fine Cross, Corsair, CXI, etc. through it to really give you a dual catheter system for extra support to do your intervention. And oftentimes what helps or makes it easy is to use really a low profile balloon, maybe a 1.5 millimeter diameter balloon, and use that as your catheter and use the guide wire. So that way, once you cross, you can immediately do an angioplasty to kind of improve the channel and get things going. So typically these catheters, when you have them, you want to advance them as distal as possible, but proximal to the point of an occlusion. You want to do a good angiogram or contrast injection, because that way you'll visualize those potential routes of communication or recanalization. So remember, just like I showed you below knee, your sheath in the common femoral artery versus the popliteal artery, in this case, it's the difference between your sheath and catheter in the popliteal artery, and specifically within a distal tibial or dorsalis pedis or lateral plantar artery, etc. Common wires that are used for these types of cases, really the Command 14, Command 18, Asahi, Regalia, Fielder XTs. There's other, you can use V14s, as well. I mean, these are all guide wires you can use. You don't have to know all of them. Just become an expert at a few of them and get comfortable with them and use those. And that's really meant for another talk, catheter and guide wire systems. And these will really help you facilitate crossing of these tortuous and fragile vessels. So CTO crossing techniques below the ankle, they're exactly the same. The only one that I didn't mention above is what's called the parallel wire technique, which is where your wire becomes subintimal. You leave the wire there, and then you try to recanalize with another guide wire. Remember, if you have a 4 French Navy cross catheter, you can get an 014 and an 018 wire through that same catheter. And so that's something to think about. And, again, same techniques, different location. Here's a knuckle wire technique, knuckle wire from above, sitting on a balloon catheter, and I'm trying to recanalize this CTO in the foot. Here is a cart technique, which we've talked about. But in this case, I have the balloon from below, and I was able to create a channel and recanalize. Here's a reverse cart, like I just showed you, balloon plus a knuckle wire, right? It just kind of looped on itself. So as I deflate the balloon, then I try my recanalization from below in a reverse cart technique. And then obviously in this case, I'm doing double balloon at the level of the ankle joint and below to recanalize through here. And you can see there's dual access from above and below. So what about treatment now? So there's some important key points regarding treatment. Remember that recoil in tibial vessels and in below ankle vessels is really high. This is a nice study out of Switzerland where they basically did an angiogram. They fixed the tibial vessel. They waited 15 minutes, did another angiogram 15 minutes later. And in 97% of the cases, there was a third of the lumen was gone, was lost. That's how much recoil they got. So when you think about a 2 millimeter or a 3 millimeter vessel and you're losing a third, that can make a big difference in terms of perfusion pressure and flow. So the point of this is you want to really size your balloons appropriately. Most people think of tibial vessels as, well, I'm going to use a 2 millimeter or 2.4. But if you look with intravascular ultrasound or even IVUS, extravascular ultrasound, putting it outside and looking, a lot of these tibials will measure down to the ankle joint 3 millimeters, and up near the TP trunk and higher 3.5, 4 millimeters. And so you can see if people are using 2 millimeter balloons in tibial vessels for the entire length of the way, you're really undersizing. And you're going to lose about a third of that lumen within 15, 20 minutes. You've really kind of now haven't really made that much of a difference because it's not going to stay open, because we know it affects patency rates. So what about treatment now? So we know that I kind of mentioned it already. IVUS, in my opinion, and I think in most people's opinion that do heavy CLI work, is really important for accurate vessel sizing prior to angioplasty. Because when you look at angiograms and try to either measure with the angio equipment and say, oh, let's measure that stenosis, there's a couple of there's quite a few papers out at this point, and I can send one to you if you want, that shows you how you undersize balloons using just angiograms. IVUS is much more accurate, and you'll see the difference if you start using it if you haven't in the past. And so it's really accurate, but you got to remember, if you're going to use IVUS, you need a channel that's at least 1.5 or 2 millimeters, or sometimes that IVUS won't track. And so if I can't get an IVUS to track, meaning an 018 IVUS to kind of course through a CTO that I've recanalized, I'll use a 1.5 millimeter balloon and escalate up to 2 millimeters just to get the IVUS in, because I want to see how many times did I go intraluminal and subintimal, and all those things will affect how I do my atherectomy in some cases. In terms of pedal loop reconstruction, I try to use one long balloon that covers the entire pedal plantar loop if it's all abnormal. I think it minimizes your time. I think it minimizes radiation. It minimizes your risk of exchanges with multiple balloons and lengths and sizes, and hopefully will reduce your chance for dissection and perforation, because you're doing one long, prolonged low pressure inflation which we know decreases the chance for dissection and complication. And you want to keep these balloons up, below the knee. Most people will say 2 minutes, maybe a little bit longer. Below the ankle, I think you want to do 2, 3, maybe 4 minutes. You really need a prolonged inflation. So obviously below the ankle, you're going to be doing several balloon inflations sometimes to achieve really a less than 50% diameter stenosis. So, in pedal loop interventions, you're not going for the perfect textbook, this, oh, look at that, that's beautiful. You're going for really less than 50% diameter stenosis without any flow limiting dissections. People always ask me about, well, what about vessel prep below the ankle? Well, there are people that do it. I tend to do really orbital atherectomy because I think that's the safest in my opinion, but some people will use what's called the chocolate balloon by Medtronic, and that kind of has a nitinol cage. It's like a sculpting balloon, but you need a vessel size that's at least 2.5 millimeters. Otherwise it gets stuck. Same thing with atherectomy is that you typically want to go at a low speed, but again, there's not a lot of data for this. So depending on who you talk to, they may give you different answers, but this is kind of how I do it. But the bottom line is below the ankle, if you're going to use any of these things, you got to be really experienced because these things can get stuck, they break off, and it can be disastrous consequences if you're not really quite familiar with them. Finally, what about prolonged angioplasty? Everybody always talks about, oh, do you keep your balloon up for 30 seconds, a minute, 2 minutes? Here's a meta-analysis where they looked at, prolonged balloon angioplasty versus just inflating it and taking the balloon down. And although some of the studies were weak and overall kind of weak data, they did show that really prolonged angioplasty of at least 60 seconds was really associated with a better post-angioplasty result. And so I think most CLI operators today will definitely keep balloons up for 2 minutes. And then beyond that really depends on the person. And I think below the ankle, definitely 2 minutes and definitely maybe even longer. And here's like a small example of that. If you look at this, you can see this is a patient CLI with ulceration and the distribution of this distal DP and proximal perforating artery occlusion. Basically, here's that diagram, and here's that recant I was showing you. So let's show you what that recant actually looked like from start to finish. So again, to remind you, I have a catheter and I have a CTO wire, low gram tip load, and you can see where it prolapses at that red arrow between the base of the first and second metatarsal. That's the classic location for that first bend or turn into the perforating artery or the deep perforating or communicating artery. And then at the base of the third should be my next turn to get into the lateral plantar artery, and then there it is in this case. And that, whether it's base of third or a little bit farther, depends on your obliquity. So the more AP your foot, the better. And there's the recanalization, far top left. I've showed you this. We made sure that we're intraluminal, which we are. We did orbital atherectomy in this case to vessel prep and get it going. Nice long angioplasty, and then you can see the final result on the lower right there to achieve a nice open channel. So in summary, try to become an expert at below knee and below ankle anatomy. You really have to know the anatomy to the next level of what you thought you knew. You want to really perform high quality angiograms, and I think AP views of the foot plus the typical lateral foot that most of us are used to, and try to keep your sheath or catheters as distal as possible. Oftentimes when I'm dealing with below ankle anatomy or disease, I'll have the sheath in the popliteal artery, I'll have a catheter in as distal as possible in one of the tibials, and I'll do a dual injection, and you'll be amazed how much stuff shows up that you didn't see. Use your angiograms to assess the cap morphology, collaterals, distal targets, help determine your access sites and whether you're going to be dealing with a direct or indirect revascularization. Remember, perfusion is not always predictable and based on direct angiosome concept. Consider additional and alternative access sites as needed, like we talked about. Become an expert at CTO Crossing Techniques. Go watch people, watch live cases on YouTube, etc. Go to courses that focus on this. I think this is probably one of the most important things when dealing with CLI patients. Remember accurate balloon sizing. You are going to lose some, you're going to get recoil, so you want to optimize your lumen gain by using proper angioplasty sized balloons, and keep them up for 2 minutes, low pressure. Even if you're when you look at the sheet on the balloon, it says, oh, nominal is 8 atmospheres. If you're fully profiled with that balloon at 4 atmospheres, just keep it there. You don't need to go to 6, 7, 8. because you've already inflated this to the maximum dimension of 2 minutes. There's no reason to go to those high pressures. And doing low pressure balloon inflations like that for 2 minutes or more, you'll be amazed what kind of optimized results you'll get. And you'll also reduce your chance for dissections and perforations. Remember, IVUS and even EVUS, external ultrasound, can be very helpful in terms of sizing and for looking at your, assessing your vessel pre and post if you have time. And obviously, I think scoring balloons and atherectomy, in other words, good vessel prep, is key for the tibial vessels. And below the ankle, I think I would start with a 1.5 millimeter balloon and kind of escalate up to 2 millimeters if you're able to. Know your limitations and always ask for help. I still ask, a lot of my colleagues and friends for help. Why don't we stop there in case there's questions and stuff. What do you think, Abhi? Because this is the last case, but I don't need to really show it because I went over a lot of stuff.
Thanks, Rini. That was great. Yeah, I think we are kind of approaching the end of our allotted time. That was actually a great talk, man. Really awesome.
Thank you.
Actually, a lot of the questions on here that people are asking, you subsequently answered in your talk. So that's kind of awesome. I was going to ask you, so in terms of when you talk about preparing for these cases and, even evaluating these patients with CLI, what's your approach on, the non-invasive tests you would order before you see a CLI patient with a wound? Are you getting, arterial Doppler ultrasound, kind of game planning before you go to the angiogram? What do you prefer?
Yeah. I mean, I think it really depends on where you work, your hospital system and what you can get. For me, here in Miami at University of Miami, it's really hard to get a CTA or an MRA. It just takes a long time. And remember, most of these patients, their renal function is not great, or they don't want to come back and forth numerous times. But so our algorithm at University of Miami, and a lot of, I think, people down here, is that I will see the patient. I will definitely get PVRs, segmental pressures, ABIs, and TBIs. Obviously in diabetics and CKD, you want TBIs because those are more accurate than an ABI, right? The ABI is typically artificially normalized or elevated. Right. Somebody like that. And so I'll get that as my first test. And in addition to that, I add on a duplex arterial ultrasound. So now I've got all this information physiologically, and I've got waveforms to see what's open, what's not, where's their disease, and so forth. And if you're able to get a CTA or an MRA in addition to those two studies, that's like the triumvirate. That's the best case scenario, is a CTA, MRA, PVRs, ABI, TBI, and then the duplex arterial ultrasound. That gives you a lot of information of what's really happening. But our model is I typically don't have CTAs or MRAs unless I'm dealing with iliac disease or aortoiliac disease or prior surgery, or there's something that doesn't make sense based on what they're telling me, what I find on physical exam, and what I'm expecting based on that. I will tell you the other thing that's the most important that a lot of people don't talk about is just a good Doppler exam. If you have a good Doppler probe, is checking out the entire vascular, a good vascular exam. If I feel the common femoral arteries are symmetric bilaterally, they're easily palpable, I know there's no disease from the aorta to the groins, right? There's no inflow disease. At least there's nothing that's hemodynamically significant. If I have a triphasic waveform there, again, there's nothing there. It doesn't matter what I see angiographically. If I have triphasic waveforms at the groins, I know there's no inflow disease. Same thing like that. If I do a nice a palpable pulse in the popliteal. So you can glean a lot of information just from a good vascular exam. But getting back to what you were saying, I typically do PVRs, which includes all the ABIs, TBIs, and then I get a duplex arterial ultrasound, and then the good vascular exam history, and then I basically take them to the angio suite at that point.
Cool, sounds good. And there were some questions about, when you talk about staging procedures. Yeah. What's sort of your threshold now, and what do you think the threshold should be for maybe somebody who's kind of starting out? How do you kind of decide when you're going to stage it? And personally, I had a question about treating when you talk about treating CLI. There's these wounds, people who might get amputations, but what about rest pain? How aggressive do you get when you have a patient with rest pain? Diabetic smoker with all this below knee, below ankle disease.
Yeah, so rest pain in general, you don't need to fix too much. I think that's where you want to be kind of less is more conservative. I think if you have rest pain and you have iliac disease, fix the iliac, leave the rest alone. If you have rest pain and you have SFA disease, fix the SFA and leave the rest alone. If you have rest pain and you have, a tibial artery that's diseased, just fix that one tibial artery. Don't touch the rest. You know, you're basically just trying to improve the flow enough to where they have good perfusion pressure, which will relieve the symptoms. And you'll be amazed. And I'll give you an example. I had a patient that came in. He said, I've got severe chest pain, diabetic, like you said, smoker, and he had no AT. He had no PT, but he had a perineal artery that was diseased with huge collaterals to the dorsalis pedis and the posterior tibial artery. So just fixing that perineal, a short occlusion, his rest pain went away. So you don't have to do a whole lot. So rest pain, less is more. Try to be a minimalist. Don't try to fix everything. And fix it in segments. Iliac, then SFA, then tibial. And don't fix all 3 tibials. You only have to fix one major tibial that's supplying perfusion to the pedal-plantar loop or the foot, you know. Regarding staging, so staging, what I mean is, you know, staging is one of those things that's very subjective. So if I have a patient that has SFA pop disease plus tibial disease and they've got a wound, I might fix the SFA pop disease and bring them back a different day to go after the tibial disease. If I'm able to fix that SFA pop disease quickly, I didn't use much contrast, it wasn't a long procedure, the patient's not tired out, I'm not tired out, then I'll go after the tibials at the same time. So it really has to do with how long was your fix thus far, how much contrast did you use, what's the radiation exposure, is the patient fatigued and tired? Remember, these are all older patients, right? They have a lot of comorbidities. You don't want to sit on the table for 6 hours fixing 5, 6 different things when you can do like an hour here or an hour there. So that's kind of the way to think about it. So I think staging procedures is very important. Hopefully that makes sense, you know.
Definitely, man. Thanks. I think with that, we answered quite a few of the questions on here. And again, Srini, I really want to thank you for taking time out on a Thursday evening and doing this webinar. It was great. Thank you so much.
Thanks, guys.